Before I introduce our next speaker, I want to make sure that we are talking a little bit more about some of the foundation resources that are out there and that you have another face to a name. So if you have not already connected virtually with the foundation, there's all sorts of opportunities to do so. I like to say that whatever way you like to consume your media or your information, the foundation is putting out information in that medium. We have our weekly PD Health at Home educational programs. Those are Mindfulness Mondays, Wellness Wednesdays, and Fitness Fridays. We started that during the pandemic. It's been going now for 5 years. It's an incredible program. You can watch them live Monday, Wednesday, Friday at 1 p.m. Eastern, or you can go back and look through our library now of just swaths and swaths of libraries of different topics that you could look up and watch after the fact. So you could participate with us live, you can watch it afterwards. We have our Moving Day at Home program as well. There's a podcast, there's in-print resources, there's all sorts of stuff. And I haven't mentioned it yet, and I would be remiss if I forgot to mention our helpline. This is an incredible resource. I usually say if you walk out of here with no other information, if you learn no other things, which would be impossible, today, I hope that you remember the helpline, the number 1-800-4PD-INFO. The folks on that line are incredible. I use them as a foundation employee all of the time. They have a wealth of information there. We call them PD specialists, retired nurses, social workers. These folks have a wealth of experience and information, and they have a huge database of Parkinson's resources at their fingertips. You will get a live person Monday through Friday, 9 a.m. to 7 p.m. You can always leave a message and they will get back to you the next business day. You can send them an email at helpline@parkinson.org. They are incredible. I always say, I think of this as like twofold resources. Sometimes we have questions. Maybe you went to a doctor's appointment and you forgot to ask that question, or you have new questions and you don't have another doctor's appointment for 6 months or a year, whatever it is. This is an excellent resource to gain clarity on that. They're also incredible at the support piece too. So we get a lot of calls from newly diagnosed folks, from care partners, from adult children, from anyone who just needs to talk a little bit about Parkinson's and how it's affecting them. So really, I hope that that is a resource that you're able to use. Like I said, I get questions all the time as the community person about what's available in my area or what do I do about this specific issue, and I turn to the helpline as well. So that is my spiel about that. Call them, talk to them. They're amazing. They're really, really wonderful human beings. All right. So without further ado, I will introduce our next speaker. Dr. Vikas Kotagal is an associate professor of neurology at the University of Michigan. He completed his medical degree at the University of Minnesota School of Medicine and his residency and post-residency fellowship in movement disorders and neurodegenerative diseases at the University of Michigan. He sees outpatients with movement disorders, including folks with Parkinson's and all sorts of other conditions. He directs a subspecialty clinic for patients with suspected normal pressure this is the part where the community person has to say the science words, and I never get them right, so you all will read this on your agenda. We are very, very happy to have Dr. Kotagal with us today, and with that, I will turn it over.
Awesome. Thank you, Laura. Hi, everyone. So my name is Vikas Kotagal. I'm a neurologist, as Laura was mentioning, at the U of M and at the VA. I'm going to be talking today about falls in Parkinson's disease. And then I'll finish by talking a little bit about a clinical trial that we're just trying to get off the ground at the U of M, focused on falls in Parkinson's disease. Ideally, I'd love this to be more conversational. If people have questions, just raise your hand and I would love to talk. I've got slides here, but I would prefer to be talking to people. All right, so here are are our learning objectives for today. I'm going to talk a little bit about how common falls are in Parkinson's disease and what causes them. We'll talk a little bit about what treatments exist to reduce or prevent falls in Parkinson's disease, and then I'll close by talking about this new clinical trial. So I really like this figure. I was in clinic this morning and I was trying to, with my hands, show this figure to somebody, to a patient I was meeting for the first time, and it was not going well. So I really wish that I had this thing with me at all times. It's not that it's accurate, it's just that it's useful. So this is a figure that's supposed to talk about the natural history of Parkinson's disease, and it comes from a group in the United Kingdom in Cambridge. The black line, the horizontal black line represents time here, and the vertical black line represents disease burden. And let's see if this pointer works. Well, maybe not, but that initial horizontal black line is supposed to denote the time of onset of diagnosis of Parkinson's disease. And I think that you might be able to see that that orange staircase thing creeping up is supposed to represent the fact that as the disease progresses, people get more symptoms, and those symptoms have greater relevance for their life and for overall functional disability. HYS3 in this figure denotes Hoehn-Yahr stage 3, when people start to have more and more difficulties with walking, when symptoms that affect both sides of your body also start to affect your postural reflexes. That comes on about 4 years after the time of diagnosis in their particular data set. I think in practice it's very variable. It could be 1 year, it could be 25 years, it could be extremely variable. But in their group, that's what they found. And they also found freezing soon followed that. And in Parkinson's disease dementia, you can see there at the end of this spectrum, which seems to affect slightly over 50% of people 10 years or more after the time of diagnosis, which is to say it's not a certainty, it's just it becomes increasingly likely with advancing time and disease progression. So I also want to talk a little bit about fall. I mean, when I say falls, it occurs to me that I might mean something different than others. What I mean is by fall is an event where somebody loses control of their posture, their body, and they come to rest on, hit, or be gravity dependent on a surface below where they started. A near fall is a different thing. That might be grabbing the banister such that you didn't actually truly hit the ground, or stumbling and catching your balance. I consider those different things, near falls and true falls. Everybody in life falls, and everybody with Parkinson's disease also falls. Falls are particularly common the older you get. That's true both, again, in life and in Parkinson's disease. This figure on the right here is meant to show the black, you can see those black horizontal bars, which are the fall-free group of individuals within the last few months prior to their initial presentation for evaluation of Parkinson's disease. And you can see the older you get, the smaller that black bar gets. So age is a substantial risk factor for falls. The average number of falls per year varies based on the study in question, but both here in the state of Michigan, in studies that have been done that are survey studies, fall diary studies, and in the published literature, it seems to range between 1 to 4 falls per year is the average number of falls. And they get more common as disease progresses as well. So what are risk factors for falls? So interestingly, fear of falling is a big risk factor for falls. It probably reflects an internal knowledge that somebody is experiencing a number of fall risk factors. Having previous falls, not surprisingly, is a risk factor for falls. The thing I want to draw your attention to over here is a graphic representation of what sometimes neurologists call an inverted J-shaped curve. And what I mean by that is that the x-axis in these figures represents severity of motor impairment, and the y-axis represents likelihood of having a fall. You can see that there's not a linear correlation here, that there seems to be a linear correlation up to a point, and then all of a sudden your fall risk starts to drop dramatically, even with worsening motor progression. And what that probably means is that At some point, people just stop walking and they stop having falls because they're in a chair, they're in bed, they're not getting around very much, they're dependent on others to walk. And so this relationship between advancing disease burden and the frequency of falls isn't a linear relationship. In my experience, most falls aren't in Parkinson's disease, aren't driven by lightheadedness, though that's a common thought. They're usually driven by turning or transferring or getting your center of balance out in front of you and being unable to right the ship. That often happens in the bathroom. It often happens while getting dressed or getting in or out of bed. And a lot of falls, in my own experience, seem to happen on unlevel ground while gardening or doing yard work. What can we do about them medically speaking? Well, some falls or some propensity for falls, some fueled by motor impairment, are responsive to higher doses of Sinemet or other dopaminergic medicines. Sometimes reducing those same medicines can reduce fall risk if they're causing lightheadedness or if they're causing bad dyskinesias that lead somebody's center of gravity to lurch out in front of them while they're walking. Plenty of other medications alter cognition, reduce reaction time, and can be contributing to fall risk. Finally, there are a couple medicines that are used for cognitive impairment in Parkinson's disease, donepezil and its cousin rivastigmine. In a couple clinical trials, these have shown a benefit in fall reduction. In just as many clinical trials, they've not shown a benefit. They are generally safe and well-tolerated medicines, though, so we often try them in the hopes that they might work. The problem is that at the doses probably needed to be effective, these medicines cause heart problems and affect your peripheral cholinergic receptors much more than your brain cholinergic receptors. Other things that we do, physical therapy is helpful for some people. It's not helpful for all people. Physical therapy obviously doesn't regrow any neurons that are involved in falls, but what it really is aimed at doing is kind of strengthening your hip muscles, your gluteus medius or gluteus maximus muscles that keep your torso in single leg stance, keep it stable when you're putting on a pair of pants or making a turn. And strengthening those muscles has good medical evidence in a lot of neurologic conditions for reducing fall risk. Exercise is the same thing. Muscle wasting, deconditioning, these are big risk factors for falls, and getting regular exercise that is both good for skeletal muscle and cardiac muscle it has been shown to be effective. Is there a type of exercise? I did, in preparation for this, I did some looking into the literature. I did not find any comparative evidence that one type of exercise is better than another for fall reduction. Each type of exercise is good for its own thing, and I think that probably it won't surprise you to hear that I would recommend just having a moderate balance of multiple different types of exercise is probably in your best interest. Using a cane or a walker if you need it. A lot of people start to use a cane or a walker because of hip arthritis or knee pain. Those are actually perfectly good reasons to use those devices, but a propensity for falls is another great reason to use them. And then making home adjustments, things like grab bars in the bathroom or the shower, putting lights or track lighting such that if you get up to use the bathroom in the middle of the night, you can see where you're going. Those are also effective things for preventing falls. So this is a model I have made up, but I think it's about right for what causes falls in Parkinson's disease. So it's basically a lot of different things. So your fall risk is in the middle there. And I think you can see that I think there's some contributions from the severity of your Parkinsonian motor impairment, the severity of your cognitive impairment to react to obstacles in your way, other medical conditions, things like diabetes that can cause a peripheral neuropathy and can affect your ability to feel the ground beneath you, vision problems, intrinsic physiology, and by that I do mean deconditioning or breathing problems or other things that we know can affect your walking and standing tolerance. Extrinsic factors, which is having a well-lit hallway to walk down or walking on unlevel ground. And then PD medications, a number of medications can either increase or decrease your risk for falls accordingly. So a lot of Parkinson's medications are based around the idea of augmenting dopamine or improving the amount of dopamine you have in your brain. And this cartoon on the left here shows a number of different motor features that are made worse by reduced dopamine. Facial masking is not going to cause falls, but stooped posture, forward tilt, reduced arm swing, and a shuffling gait, these are all dopamine-linked features that can all get better to some degree or another with dopaminergic medicines and all put a person at higher risk for falls. When you add in a number of other things like rigidity, reduction in the speed of eye movements, which is a common part of Parkinson's, bladder urgency, which often necessitates an urgent need to get to the bathroom, lightheadedness, all these things are like a sandwich that kind of adds up, and eventually you start to cross this dotted red line and you're at risk for falls, whereas a few years prior you may not have been. One thing that's of particular interest to me as someone who sees both people with Parkinson's disease and other neurodegenerative conditions, including dementias, is the link between cognitive impairment and fall risk. Cognitive impairment is in my mind, is one of the key causes of falls, but it's not a cause that everyone recognizes all the time. And what I want to put forward is an idea that most falls seem to have at least a partial contribution from impaired multitasking. Most people are, when you're walking in and of itself is a multitasking activity. You're usually walking and you're looking for something, you're walking and you're thinking about either where you parked your car or where you're going next or some other thing on your mind. You're usually doing multiple things at once when you're walking. In Parkinson's disease, the capacity to multitask appears to be mediated through cholinergic neurons, which are separate neurons from the dopamine neurons. They're represented in this brain shown in cross section on the right part of the figure here with the maroon circles, and they provide innervation up throughout the deep parts of the brain and the rim of the brain. And they're involved in paying attention and shifting attention from one task to another. Lewy bodies that occur in Parkinson's disease start in the dopaminergic system, but they also occur early in the cholinergic nervous system, and they affect cholinergic neurons. But we don't have a lot of effective medicines to treat the cholinergic nervous system, nor do we exactly know who to give them to and how to measure if they're helping. And that's been a big problem with fall prevention trials in Parkinson's disease. So we when trying to design clinical trials to see if a medicine might work to improve cholinergic function in people with Parkinson's disease, part of the reason those trials have fallen apart is because we don't always give them to people who actually have losses in that cholinergic nervous system. And if you give them to people who are doing fine in a cholinergic nervous system perspective and hope to see a clinical benefit, you won't see it. What that'll lead to is the failure to demonstrate that the hypothesis actually works, that it makes sense, and that you can get the medicines to the right people in the right setting for this condition. Falls are also a hard target to design a clinical trial around. They are rare events, and as I mentioned earlier, they don't occur in a predictable or linear fashion. Some people who are at highest risk for falls might not walk at all, and you might never see a fall if you try to enroll them in a clinical trial. And those are really the people who would benefit the most, perhaps, from taking these kinds of medicines. And as I mentioned earlier, medicines such as donepezil and rivastigmine, they can help, but at high doses, they're autoinhibitors, so they inhibit their own efficacy, and they cause cardiac side effects. So they even though they work on the cholinergic system, they don't appear to be the problem for this, the solution for this particular problem. So a colleague of mine, Roger Albin, who some in the room may know, is pictured here in the upper left-hand corner. He conducted a clinical trial of an unusual medicine called Chantix or varenicline, which is a medicine used for smoking cessation, but not for Parkinson's disease. But that happens to press, it's like a key that presses on the lock that is this cholinergic receptor in the brain. It's not intended to help Parkinson's disease, but it could if given to the right people. And what he found was that people took this drug for 3 weeks or placebo, and then they switched to the other arm, taking drug or placebo. And individuals who were on this drug compared to themselves while on placebo seemed to do a little bit better at an attention test and seemed to have a little bit less slowing of walking when they were asked to multitask. So people were given a task such as start at 100 and count backwards by sevens out loud while walking down the hallway. And they did better compared to how they did when on placebo when they were taking this drug. So we're trying to use this information to say, could this actually help the right person in the right way? So we're conducting a clinical trial here in Michigan that's randomizing individuals with Parkinson's disease and some mild cognitive symptoms who have evidence of a cholinergic deficit on brain imaging to either drug or placebo over a year to see if it improves or reduces, I should say, fall risk. So this will be one of the few trials that uses a novel agent on the cholinergic nervous system. It's one of the few fall prevention trials in the country, and this is sponsored by NIH and has been peer-reviewed and is overseen by an external data safety monitoring board as well. So the trial will aim to, and we'll just got started a couple months ago, and will go for about 5 years, and we'll aim to enroll around 76 people here at Michigan. Everybody will undergo detailed testing at baseline and then have phone contact with our study team every 2 months and an in-person visit at month 6 and at month 12. And we won't know what drug people are receiving, nor will people know what drug they're receiving. They'll either get placebo twice a day or the active drug twice a day. And people will be asked to keep a fall diary at home and keep track of their symptoms. So that's it. That's the trial. I'm happy to talk to anyone who's interested about the trial or more generally about falls and Parkinson's, and thank you for listening.
All right, before I ask Katie up to present our last presenters, do we have any questions for Dr. Kotagal?
Thank you very much. That was very informative. One thing I'm wondering about for more sporting applications is there much talk about how you train people to fall? If you're going to fall, there's a way to do it and not to do it.
Yeah.
And I don't hear that talked about much. I know in sports we were taught that as well as in martial arts.
Yeah, so a colleague of, that's a great question. The question was about, actually you had a mic, I don't need to repeat it, but the question is about, is there training about how to fall? Because some ways of falling are going to be more injurious and higher risk for fractures and fall-related injury than others. I think that's really interesting. In Parkinson's disease, I've not heard of work being done on that. A colleague of mine who's a geriatrician named Neil Alexander has had an interest in that and is doing a study in older adults without Parkinson's disease to see if training on how to fall can be helpful. So that's Neil Alexander. Yep.
There's another question back here.
Yeah, I was interested in the comment about fear of falling as a predictor, and I wanted to understand that better. And I'll add that I guess I think of fear of falling as a way to prompt your attention when you're moving, which should help to prevent falls.
Yeah.
So if you could explain that a little bit further.
Yeah, I think that's a really articulate way of framing fear of falling. I think it reflects an insight into the existence of risk factors that are hard to control, and maybe even cognitive risk factors that are hard to control, including multitasking difficulties. So I don't, fear is a very loaded and judgment-laden term, but it could be phrased differently. It could say insight into cognitive deficit, and that sounds more favorable. I should think of a new way of framing that. Fear of falling is what I found in the literature, but as you describe it, I'm like, I don't love that term for the reasons that you point out. So.
Does DBS preclude you from the study?
It's a great question. I'm going to go with probably. It's not technically one of our exclusion criteria, which means that the investigators, meaning myself and Dr. Albin, have latitude to think that through. But I think we are thinking of making it an exclusion criteria, not because it's not applicable to individuals with DBS, but because it introduces an element of heterogeneity into the cohort that's hard on a scientific level to justify. So.
Is there any training being used to improve proprioception so that you can respond more quickly to imbalance?
You know, in terms of, that's a really interesting question. In terms of cognitive training, if there is, I don't know much about it, but there may be something like that. Are you familiar at all with a device called Walkisons? Is that something that you've heard of before? No, it's like a bulky sock, actually, and it's FDA cleared for diabetic neuropathy, for any number of neuropathies, but not for Parkinson's disease. The company that makes this, whose name is escaping me, has been trying to move forward a clinical trial of this device. And what does the device do? It provides sort of a sensory impulse depending on how your foot is angled one way or another. So it's supposed to help provide that compensatory information that you may not get if you have a loss of sensation from neuropathy. So in my own clinical practice, I do like prescribing it for individuals at the VA who have neuropathy and who qualify for it and who have Parkinson's disease. One of my colleagues, Dr. Bonin, who is a Parkinson's doctor and researcher, I think is either interested in conducting a trial on this for Parkinson's or may already be conducting this trial. I don't quite know the status of that. But the device is called Walkisons. I don't get paid any money by the company. Just Google it and see what you think. So.
Thank you. One last question, and we'll move on to our last speaker.
I was wondering if you had any recommendation on shoes. I found that if I had shoes with more than a 1-inch heel, I've taken the heel off from shuffling.
That sounds like a good idea. I don't have any recommendations on shoes. Well, I'm going to make something up here because I think it does vary from person to person. I will say that the more cumbersome a shoe is to get on, the less likely somebody is to wear it. And so if I was to give advice, it would be a shoe that has a grippy sole that doesn't involve bending over and tying it. I think that would be a shoe that gets worn more often in indoor, outdoor, and transitional spaces and is likely to be more effective for fall prevention. So that would be my thoughts on that. No stilettos, yes, exactly. Sorry.
Yeah, thank you, Dr. Kotagal. We're going to have to cut it there because we are on a time frame. I apologize.